It's a pleasure for me to introduce Dr. Suzanne Garfinkle, who I actually remember as a medical student. As Gabby Goldberg often says, she's a lifer. So she was born and raised in New York. She got her BA in English at Amherst, and then she got a master's in science in theoretical psychoanalysis at the University College in London. Then through the Humanities and Medicine program, she came to Sinai and got her MD. She went to Colombia for her adult psychiatry residency. Then she came back to Sinai for a child and adolescent psychiatry fellowship and chief fellow. And currently she is an assistant professor in the Department of Psychiatry and the director of the Academy for Medicine and Humanities at Sinai. She's done a lot of teaching, which started in medical school. She created and oversaw the Writing About Medicine course with Dean Muller, and then she was involved in the narrative medicine program at Columbia and actually taught writing the psychiatry history of the present illness to both students and residents, and then taught normal child development to students and residents. She's had a number of honors, including 2 fellowships in the field of psychiatry, the Ginsberg and the PRITE Fellowship. She's going to talk today about the best practices in medical humanities education.
Thank you. So, good afternoon. Today I'm going to talk to you about best practices in medical humanities education. I'm going to start by providing a rationale for the use of medical humanities in the training of doctors. I'm going to talk to you about what the goals are of these programs, as well as the specific methods they employ and the evidence behind their use. Then I'm going to move to a discussion of the best practices in the area, and then discuss challenges in our field, as well as future considerations for future directions, like critiques by students, debates about what content is most important, and discussions of standardization and assessment. So, every discussion of medical humanities starts with talking about a problem in medicine. And the problem has something to do with humanism. This picture captures some of it. In the picture, we see a patient who seems powerless, uncomfortable, with faceless doctors towering above him, buried in their charts. The image evokes many of the areas that people tend to complain about when they're unhappy with our medical system. Poor doctor-patient communication, the failing of the doctor-patient relationship, decreased patient satisfaction, increased physician burnout, all of which lead to chronically problematic health measures like poor adherence to care. But even if we don't agree on which of these issues is the most important, we could probably agree that humanism is suffering in some way in medicine. And when we think about why there's a problem with humanism in medicine, we can again point to many different factors, usually some combination of time and money pressures, causing a great divide, as we see in this picture, between the world of administration and bureaucracy in the background there, and the world of human suffering in the foreground. These kinds of troubles are often attributed to managed care, with the high patient volumes we're required to carry, the brief clinical interactions we're forced to have, long work hours, diminished salaries, lots of debt, as well as clinical issues like poor continuity of care, over-specialization in medicine, diminished status of the primary care doctor, the emphasis on labs and tests that leads many of us to question the need for long, involved conversations in everyday practice. To make this elusive problem even more confusing, many of the causes directly oppose each other, like poor continuity of care, resulting in part from efforts to mitigate long work hours. Many people believe that the problem actually starts earlier, with our educational structure. Pre-med requirements that are too focused on the hard sciences, a culture in medicine that is hierarchical and often unforgiving, cynicism that is passed to medical students via the hidden curriculum that we all know so well. And it's been well documented by now that whatever humanism we start off with as beginner medical students can be crippled along the way through our training. And we've seen this in our Morshan Center, a phenomenon described in the literature that empathy tends to degrade in the third year. To solve these problems, we've come up with new concepts: patient-centered care, professionalism, competencies issued by multiple accreditation organizations, attempting to pinpoint what it is that we need to work toward. Flexner, in 1910, argued that in addition to studying science, humanities education and the acquisition of humanistic skills were fundamental to the training of doctors. The AAMC in 1998 said that it was important for doctors to be altruistic, compassionate, and empathic, and to strive to understand the meaning of patients' stories. The ACGME general competencies for residents state respect, compassion, integrity, and sensitivity as chief among them. The LCME, JCO, the NBME, the USMLE all make similar statements upholding these kinds of goals. And most recently, in 2011, the AAMC put out a report prioritizing self-awareness and reflective practice. Medical schools have responded to these edicts. There's the Gold Humanism Honor Society, privileging humanism among medical students. Every medical school has its doctoring course that, as we know, attempts to teach everything under one umbrella. There's been an emphasis on small group learning and problem-based learning, both of which tend to train humanistic skills more than lecture-based learning because they emphasize collaboration and the consideration of individual cases. So medical students can acquire these skills. Medical students are great at acquiring skills. The problem is they don't always go on to use them. And the problem is not that we or that they don't value good communication and empathic patient care. One study found that even doctors who were specifically turned off by the term medical humanities were found to prioritize the same goals, like personal and professional awareness and self-critique. So if we can acquire the skills and we value the skills, what's the problem? What makes us not live up to our own standards? A recent article in JAMA talked about the syndrome of burnout. They defined it as emotional exhaustion, depersonalization, which means treating patients as objects, a low sense of accomplishment, leading to poor patient care. And maybe not surprisingly, this phenomenon was rampant among physicians. 60% in practice described symptoms of burnout. But what I thought was even more surprising was that 50% of third-year medical students at the very beginning, when they're supposed to be the most optimistic, excited, engaged, also described symptoms of burnout. The authors of this article proposed an antidote to burnout: mindfulness, or being present in the clinical interaction. I believe these authors are onto something, as much as I personally don't like the sort of Zen terms of mindfulness and the idea of being present. I think we're still struggling to find the right language for it. But I think that this is something that we all struggle with, even those of us who would not specifically describe feeling burned out clinically. And so the problem is not just one that affects doctors who become clinically depressed or suicidal or who leave clinical practice to go work for industry. The problem that concerns us involves the everyday clinician who is not quite able to rise to the level of humanistic practice he or she aspires to. This is the doctor who would like to be a little less stressed out, more gracious, more thoughtful, more patient, more curious, and more available in some way to his patients. Danielle Ofri, who is the editor of the Bellevue Literary Review and writes a lot, published an article in the New York Times last spring describing a time when she was unable to give a patient her full diagnosis and prognosis due to her own emotional difficulties doing so. Reflecting on this as a more mature physician decades later, she sees this as a systemic problem. By now, she writes, even the most hardcore old school doctors recognize that emotions are present in medicine at every level. but the consideration of them rarely makes it into medical school curriculums, let alone professional charters. Typically, feelings are lumped into the catch-all of stress or fatigue with the unspoken assumption that with enough gumption, these irritants can be corralled. Balint said famously that the doctor is the drug. If we want to be more effective using ourselves as the drug, we have to become more comfortable using reflection in our practice. So now I've provided a rationale for the enhancement of humanism in medicine through training in reflection. I will spend the next portion of the talk describing how the medical humanities specifically address this problem. Let me take a minute to make one important clarification. Humanities does not necessarily entail humanism. Humanism is a set of values and a way of life. Humanities are a group of academic disciplines. I'm sure we can all think of the English professor we had in college who we would not want to have treating us medically. However, in some cases, study of the humanities can cultivate humanism, and I will try to draw those lines as clearly as possible when discussing what we teach and what we hope to accomplish. So let's start with a basic definition. The medical humanities is the application of humanities, social sciences, and the arts to medical education and practice. I will describe to you the trend as it's occurred in pre-med curricula, in medical schools, and in our literature as well. So in 1984, in a report from the AAMC called General Professional Education of the Physician, they described a college preparation for medicine that unfavorably narrowed the undergraduate education. And this, among other factors, was one of the impetuses for the Humanities in Medicine program in 1987. As we all know, I think everybody here has a sense of what the Humanities in Medicine program is. These students have been found to do well in medical school. A recent study found that 700 students found that HUMEDs showed greater interest in primary care and psychiatry, with fewer going into more procedural fields like surgery and anesthesia. Interestingly, these humanities and medicine students also showed greater participation in research during medical school. But nothing dictates what pre-meds tend to study more than what's going to be covered on the MCAT. Humanities used to play a significant role in the MCAT, and the tides are turning back that way again. From 1942 to 1976, the MCAT included a section called Understanding Modern Society. Liberal arts questions were eliminated in 1977 with the increase in emphasis on technology and medicine, and that is how things have persisted to the present. However, the new MCAT that goes into effect in 2015 will place a renewed emphasis on social and behavioral sciences, as well as critical thinking. As Daryl Kirsch, president of the AAMC, recently said, the goal is to improve the medical admissions process to find the people who you and I would want as our doctors. Being a good doctor isn't just about understanding science, it's about understanding people. Within the past decade, it's become increasingly common for top medical schools to offer formal programs in the arts and humanities that are integrated with medical training. Of the current top 20, most provide at least one required course. And at least 5 in the top 20 offer comprehensive programs in medical humanities. This trend has also been reflected in our literature. One recent review found that over 1,000 articles were published on this subject between 2000 and 2008. This stream of publications has appeared in the highest impact medical journals, including the New England Journal of Medicine, the BMJ, JAMA, Annals, and The Lancet. Academic Medicine has produced 2 theme issues on this subject, and the trend in the literature continues through the recent present. The January 2012 issue of Academic Medicine contained a forum on reflective writing courses, including a new evidence-based tool for assessing reflective capacity through these exercises. So I'll spend the next portion of the talk focusing on the nature of medical humanities programming specifically, including our goals, methods, and the evidence supporting its use. The clinical encounter begins with observation. As any of us who've ever seen a patient know, observation is important for establishing a meaningful connection between patient and doctor. That's also been studied. We also know that careful observation, slow looking, is useful in the gathering of key information, key medical information, that is more useful diagnostically than the masses of information you can accrue through just simple question and answer without the observation component. We also know that nowadays with the electronic medical record, we look at our patients less than we used to. In fact, one recent study out of Israel found that 25 to 42% of the clinical encounter is spent looking at the screen and keyboarding. Although this does correlate with an increase in the amount of biomedical information exchanged, there is a decrease of psychosocial question asking, and patients experience less emotional responsiveness from their doctor who is looking at the screen and keyboarding. But even if you accept that we need to work on our visual abilities, you might argue that looking at art is not the only way to do so. We could, for example, just spend more time on observational aspects of the physical exam. It turns out that while methods of teaching observation are effective in training diagnostic skills like pattern recognition, arts-based teaching using visual art does the same thing in terms of training diagnostic skills like pattern recognition, but also adds insights about relationship, narrative, and empathy. And so the real reason we advocate for the use of visual art is that in the process of building this core physician skill, observation, it also prepares the physician to observe, describe, experience, and respond to emotional states. So I'm going to give you an example of a course that does this. This is a course at Harvard called Training the Eye, Improving the Art of Physical Diagnosis. It's a 9-week preclinical elective with observation sessions at the Boston Museum of Fine Arts, followed by a lecture by an MD. And the technique that they use for the observation component is a technique called visual thinking strategies. This is a technique that's used to train lay people in how to look better, how to look at things better. So it's used in teaching school groups, in teaching police officers who have to hone their observational abilities. And it was created by a psychologist and an art educator to foster empathy through increasing these observational skills. So the VTS model is very simple. It asks 3 questions of the observer. What do you see? What do you see that makes you think that? And what more do you see? So in this course, after the observation session, the MD would link the visual arts concepts of the day to physical diagnosis. Topics included texture and pattern with application to dermatology, contour with application to thoracic radiological imaging, and line symmetry and balance with application to neurology. There were also weekly homework assignments in visual observation. One example that I liked was carefully observe 3 people whom you see regularly and document in your journal any new observations you previously had not noticed. Please pay attention to form, including posture, shape, and body proportions in your general assessment. Now, the real reason that I'm telling you about this is they studied the impact of the course through a prospective, partially randomized design. Students would be shown, and they had their control group was interesting. It was students who wanted to take the course but didn't get into the course, eliminating selection bias. And then the control students were then compensated for their time in taking the surveys. So there was a pre and a post test, and students would be shown novel images, both artistic images and medical images, and they would be given a few minutes to free text their observations. And they were given 1 point for each accurate observation that they made. participants in the course showed not only more numerous observations and but also more accurate observations than the control students. And very interestingly, students who had attended 8 sessions showed a greater increase in their mean change score, a significantly greater increase, than the students who had attended only 7 sessions, suggesting a kind of a dose effect of this program. So, let's imagine for a moment that we're doing the exercise. And we actually have one of our current art instructors here in the audience, so I'll call on you, Bobby, to speak a little bit more after we go through one round of this. Okay, so this is a photograph by Reneke Dijkstra, who is a Dutch photographer at the Guggenheim currently. So I'll start. Any volunteers? Dan?
Yeah, it looks like this is a woman who's almost naked, seems to have just given birth to a baby. It's striking because we're looking at someone who, in a clinical setting, we would say, oh, this is a normal, healthy woman, just gave birth. This is a very joyous moment. But it's hard to see her face from this far back, but it's, the expression to me is a little serious. That's kind of what I'm getting.
Uh-huh. So if we were doing the exercise, I would ask you to then support that with what it is that makes you think her expression is serious. But since we have our real art expert in the audience, I'll turn it over to Bobby. And if you want to just say a couple of things about this picture.
Thank you. I just want to say that our group, the Pulse of Art, actually had a special tour of the Dijkstra show this past Monday night. So we were able to stand in front of this along with 2 other pictures of postpartum women. And just to tell you some of the points that were elicited by having our medical students and senior physicians in front of it. So one of the things that's very interesting is that in Holland, the Netherlands, most of the women give birth at home. And the artist, the photographer, knew this particular woman very well. And her series started with this because they had a close relationship. So she was invited to come to the birth. And as a photographer, she kind of collaborated with the subject and was then there was a trust relationship. One of the things that the physicians noted was the protectiveness of the new mother with the baby, and how each of the 3 mothers who were photographed seemed to cradle and protect the child. The group leader told us that child, the mother had her hands over the eyes because there was a flash, and it was a protective gesture to protect the very young infant from the flash. We also talked about the kind of uncomfortable or unusual relationship because this subject, as you can see, knows she's being photographed. And what came up was that most new mothers are looking down at the infant, and there is that kind of total gaze between the mother and the infant. But there is a little bit of something that's unusual about this because the mother is not looking, even though she's protective. She's really looking straight at the photographer, which turns out to be straight at the audience. So there's something a little bit compelling and unusual about the way Dijkstra has captured this mother, new mother. The 2 other photographs that are near it at the Guggenheim have a postpartum mother a few days after, and then another one that's more than a week because it was a cesarean section. But all 3 are standing up and looking at us. And one person in the class said there's something very primal about this. And so I'll leave you with that word, that there is something primal about this right after.
Thank you, Bobby. That's Bobby Kohler, everyone. So you can imagine as a medical student being exposed to hundreds of iterations of what do you see, what makes you think that, what more do you see? What do you see, what makes you think that, and having a certain kind of sensitivity then when going into a patient's room, being tuned in to observe details in a different kind of way. So moving from observation to listening. So we all know the value of listening in obtaining quality medical information, as well as in creating strong relationships with our patients, as well as better clinical outcomes. But our lack of listening at this point in history has become a cliche. When David Muller and I went into the president of Lincoln Center's office to talk about how we were possibly going to set up a program together, the first thing he said is, "Doctors don't listen." And that was sort of the starting point. So those of you who attended the Art of Listening can't answer, but I'll have a pop quiz for the rest of you. How long before we as doctors interrupt our patients? 10 seconds. It's a little better than that. It's 23 seconds.
It's not so great.
It's still not so great. And how much time do we doctors spend with patients who are hospitalized on a given day? Anyone?
10 minutes. Depends on the specialty.
10 minutes? Close. It depends on the specialty. These were internists who were followed in Germany, actually. So maybe we're doing better in this country, but in Germany it was 4 minutes a day. And then how many seconds or minutes do we spend with their concerned family members on a given day in the hospital?
23 seconds.
Oh my God, you are a cynic, Dr. Barnett. It's actually worse. It's only 20 seconds. So we still have a lot of work to do.
It looks like I'm an optimist.
So using music might be one way to train listening skills, but it's not the only way. We could, for example, just spend more time practicing listening in conversation with patients or listening to each other. But it may actually be more efficient to use music. Music is often described as the most basic of all of the arts in its connection to emotion. Like with visual art, one cannot listen well to a symphony and describe it in any meaningful way without reflecting on its emotional statement. We can make a similar argument for its use in education. The physician has an opportunity to practice emotional reflection while acquiring a core skill. There's been some theoretical work in this area. For example, using jazz as a model for improvisation in the clinical encounter. And other work discussing principles musicians could teach doctors, such as the importance of performance. You're only as good as your last performance. And the benefits of examining structural elements such as tempo, rushing it ruins things, and counterpoint, hearing two perspectives at the same time. Do we in medicine have theories about listening? About how to use silence? About what our obstacles are to listening well? In psychoanalysis, these clinical issues are fundamental, but even in general psychiatric practice, they're pretty marginal. People who study music think a lot about listening, as we saw in the Art of Listening when we heard from our non-physician musicians. We know little about the impact of music on training physicians at this point, but given the centrality of listening to our job, it is a question worth considering. Which brings me to the final and most fundamental example of medical humanities, narrative studies. The clearest and most well-developed area making use of the humanities in medicine is in narrative studies. As humans, we understand ourselves and each other through stories. These take different forms depending on who we're talking to. For example, we explicitly communicate in medical narratives with each other, doctor to doctor, and these medical narratives are what we try to elicit from our patients to make diagnosis and treatment clearer. But consideration of the patient's narrative, which is often very different from this, containing the meaning of their illness to them, this is often missing from our consideration. If we pay attention only to our doctor narratives, we run the risk of sabotaging our treatments. We can do this by focusing on outcomes that are more important to us and ignoring those that are more important to our patients, things like small but very disruptive side effects that we think are minor but are a huge life-changing deal to our patients, or by our prioritizing resolution of disease and longevity over quality of life. We can do this by alienating our patients and then causing them to not be so adherent, or worse, to try to sue us, to get angry. And then the very worst is that we can make irreversible mistakes clinically, like the case of a physician in Oregon who would take requests for assisted suicide at face value without inquiring about the psychological meaning of this to the patients, because he found that was distressing to patients. That's an extreme case, obviously. We could teach something about personal meaning without using literature. Oops. Sorry about that. I'm getting some feedback. About personal meaning without using literature. Social history and asking patients what matters to them, which we do anyway. But that would ignore the physician-enhancing benefits of reading, preparing our minds not only intellectually but experientially. Recent neuroimaging suggests that reading literature, which makes use of rich language and metaphor, activates our sensory cortexes as if we were experiencing the event directly, whereas phrases matched for meaning without these poetic qualities did not. Doctors who read fiction might, in a sense, gain life experience and wisdom without having to see twice as many patients or work for decades and decades. 2 recent studies out of Canada reported that individuals who frequently read fiction are better able to understand and empathize with other people. This was even after they had eliminated selection bias in the study. Theory of mind, or the ability to imagine another person's perspective, was directly related in preschool children to the number of stories they had been read. But according to what we know about theory of mind, you cannot imagine what's in someone else's mind unless you know what's in your own. Reflective writing, the bread and butter of medical humanities, has been widely implemented, more than any other activity in the field, and has also been studied among patients as well as trainees. Among patients, writing about stressful experiences was found to reduce symptoms of asthma and rheumatoid arthritis. And for students, reflective writing about test anxiety was found to boost exam performance. Reflective writing is free, it's efficient, and can either be shared or kept private, making it an accessible and relatively non-threatening avenue for training reflection in med students. Is the battery? Can I just yell? Can people hear me? Okay, that's fine. Okay.
I thought you were sending your message
Oh.
Okay.
I hope I don't have to resort to Morse code for this group. Okay, so I'll just speak loudly. Okay, so here's an example of a program, a comprehensive program that makes use of narrative. This is Colombia's program in narrative medicine. The program was established in 1998 by Rita Sharon, who's an internist and a PhD in English literature up there. And its goal is to develop narrative competence, which is defined as the ability to understand the meaning of illness and medical treatment to a patient, and to improve communication, and to achieve better outcomes of care. Narrative training cultivates the ability to acknowledge, absorb, interpret, and act on the stories and plights of others. So this is a longitudinal program. It starts in the first year with 1s and 2s having selectives. This is a menu of offerings in the narrative medicine program. They must take one of them. They can choose which one. All of their work over the 4 years goes into a portfolio that they call the shoebox that's used in their general assessment as a medical student. They get a mentor in narrative medicine who follows them all the way through. And the highlight of the program takes place in the third year with the parallel chart exercise, which is an opportunity for them in the context of their medicine clerkship to write about the patients that they're caring for, to write everything that is affecting their patient care, their feelings, what we would refer to in psychiatry as their countertransference. This person reminds me of my grandfather. It's really hard for me to walk in the room. I try to spend very little time with him. It's too painful, etc. Things that you would never write in the medical chart that would be inappropriate for that. And so that's the exercise. And every clerkship now contains at least one narrative medicine section. And I'll talk about the impact of the parallel chart exercise and what that does for the students. But the program has really kind of become very prominent in the medical school. And so now it's not just the medicine clerkship, but now it's all of the clerkships. And they have one session where the students are asked to write reflectively in response to a very carefully developed prompt. They have a faculty member whose job it is to find the prompt for neurology and to find the prompt for OBGYN, which is usually a literary passage that's thought-provoking. So the neurology one is, something about hopelessness, for example. And they do that one day in each session, in each clerkship. There's an elective in the fourth year that attracts students from all over the world. I used to teach in that seminar. And you can get a master's in narrative medicine at Columbia. There is a monthly narrative medicine rounds in the evening, a monthly literature seminar hospital-wide, so it attracts students, researchers, MDs, and there are also individual narrative medicine programs in specific departments, like the pediatric oncology department gets together and they write about their experiences caring for their very sick patients there. But most importantly, the hospital culture has meaningfully integrated narrative medicine. So I have lowercase e there because this is not evidence as in the literature, it's evidence as in a cultural shift to integrate this program. For example, whereas faculty teaching in the medical school, teaching narrative medicine, were originally paid only through the NIH grant, even though the NIH grant is still active, the medical school has taken on the funding of these faculty because they see them as so integral. So, but on to the other kind of evidence, the kind of evidence that we generally speak about. This program and the narrative medicine movement in general has taken the question of evidence quite seriously. Multiple studies indicate participants in reflective writing exercises, from medical students to pediatric oncologists, experience an increase in empathy for their patients after doing this. They experience a decrease in burnout. They can make more coherent case presentations, and they feel more prepared after these exercises to have meaningful conversations with patients and families. Ratings of these courses are typically high. A recent study involving reflective writing showed that participants in the program had improved mood, were more empathic, and showed other behaviors associated with improved patient trust, appropriate prescribing, reduction in healthcare disparities, and lower healthcare costs. So I've talked to you about the rationale for medical humanities, about the goals, the methods, the evidence, and now we're going to talk about the implications for medical education. So these programs do not always succeed. A recent literature review found several reports of reserved attitudes about using the humanities in medical education. Here are some reasons why they don't succeed. And these are mostly critiques by students. There's the liberal arts education critique. That means I just went to college. Why am I doing all of this again? Now I want to learn medicine, kind of an intellectual bait and switch. And that often happens when the people teaching in these programs are not clear on the purpose and how it is directly related to medicine. On the other extreme, when the instructors are overly heavy-handed about the purpose, that this is to make you a humanistic doctor, medical students are kind of turned off by that, the doctor's moral development critique. They experience that as condescending. Then there's the supportive mental retreat critique. This is the very common phenomenon where students kind of see it as like a soft experience, and the instructor's very touchy-feely, and everybody thinks it was nice or relaxing, but there's no real substance that's clear to everybody, and it has this sort of double-edged sword of being uncomfortably exposed emotionally to your colleagues and under-challenged intellectually. So, the comments nice or relaxing are weak praise that are really part of this critique. Then there's the trustworthiness critique, which is that oftentimes our best instructors in these areas are non-MDs. And medical students like being taught by MDs. They arrive in medical school, they want to find role models, they want to know how everything relates to what they're going to be doing. So they often get a little uncomfortable if it's, just an art historian in the room without an MD. Like, how do we make that connection? And then finally, there's the structural critique, which is on the part of medical school administrations, which is, this is nice, this is great, this is very interesting, but we just don't have time or space for it. There's so much else we have to accomplish. Which really sends the message that to rigorously learn humanism is optional. So, in light of all of these critiques, how do we possibly have a successful program? Well, there are two qualities that make for a successful program. One is its academic seriousness, and that has several components, and then the other is its institutional validation. So in terms of its academic seriousness, you've got to have at least some required elements, because if it's all elective, it's really sending the message that that's what it is. It's elective. You could survive perfectly well without it. Then, there's the problem of it's got to be something longitudinal that students experience again and again as they go through the steep developmental process of medical school, not just an arts day here and there, humanities experience here or there. That tends to feel more like leisure than like part of a process that they're engaged in. You've got to have dedicated faculty. That's people who don't just sort of say, oh, I majored in, classics in college, and I really like this one poem. Can I teach a course in it? You've got to have people who really know what they're doing, who know how to speak to medical students, who know kind of where medical students are in their developmental process, who can make connections between this and medicine. Obviously not overly heavy-handed connections, but not no connections. And ideally, these are people who are involved in a community of humanities medical educators who talk to each other, who compare notes with each other, who have a sense of the greater program than just their one individual course. And then finally, there's been some debate about what should be in the medical humanities. There are a lot of categories under arts, humanities, and social sciences, and there's a movement in Germany now toward the harder medical humanities. So metacognition, thinking about how we problem solve, thinking about how we think about issues, more philosophical humanities. And students love those courses. They've kind of taken over. And I think they find them very easy to relate to. They're on the less touchy-feely side. They're much more cerebral, but also fall within humanities and what is not typically taught as part of a medical curriculum. So, and then in terms of institutional validation, what do medical students care about? They want to be acknowledged for all the hard work they're doing with their precious time. This can occur in the form of awards and fellowships that are given, like the Gold Humanism Fellowship and others. It can occur in the form of degree credentials. Several programs now are giving PhDs or giving concentrations or distinctions in medical humanities for unusual work in that field during the course of med school. You've got to have opportunities for independent scholarship in this area, and also a wide presence in the institution. So involving attendings, involving people from all different departments, involving house staff. That also sends the message that this is not just an experiment for the medical students, this is something that matters to doctors who are in practice. So I'm going to tell you about a successful experiment in this area. In one of the only longitudinal studies that we have to point to in the field, it was found that this was the New Pathway program at Harvard. Medical students were randomized to this New Pathway program, which emphasized humanism, including the study of medical humanities, reflective writing, everything that I've been describing. And these students were significantly more likely than their control colleagues to demonstrate certain outcomes. So in medical school, they were found to have better interpersonal skills. In residency, they were found to be more likely to go into primary care or psychiatry, more patient-centered fields. And 10 years out, they managed to track down these students. And they found that they were twice as likely to have remained in primary care and described more confidence handling complex psychosocial issues in their patients. So this is a very exciting time in medical humanities. There's active debate in the community about a lot of things. For example, whether or not to tether our curricula to core competencies. There's a lot of pressure to tether everything, as we know, to core competencies. But in a sense, the medical humanities have always stood as a counterpoint to reductionism. So this is a debate that's raging within the field. And what's the best way to assess the progress of students in these courses? There are people who are busy validating instruments to provide more objective measures of students' reflective capabilities. This instrument I described that was published in Academic Medicine last January that assesses, how reflective is your reflective writing essay. And then there are those who've advocated for, less concrete measures, like the use of portfolios or the shoebox at Colombia, to sort of have a more impressionistic description of the student's progress during medical school. There are new voices in the debate about the content. Should it be the harder medical humanities, social sciences, philosophy, thinking about thinking, or more focused on arts and, what's been referred to as the softer medical humanities? And finally, there's been some thoughtful pushback against the idea of medical humanities as compensating for a deficit. Now, I know I've described this as compensating for a deficit, because I believe in some way it is compensating for a deficit, but others feel that instead we should promote the possibility that humanities analysis genuinely becomes part of the everydayness of learning medicine, reflecting just how close to the heart of medicine the humanities lie, deficit or no deficit. So I'll take a minute just to talk about Mount Sinai, because I know several of you are probably wondering what I'm doing and what we have going on here and what's going to be for now and for the future. So Sinai has long cultivated a reputation as a leader in patient-centered care, professionalism, and reflective practice, I think, as we can all say with pride. The HUMED program, which is unique to Sinai, has contributed to the caliber of medical students graduating from this medical school. And despite acknowledging the clear benefits of a broad liberal arts education to personal and professional development, Sinai historically has offered not that much to support study of medical arts and humanities within its curriculum proper. At Sinai, there have been many efforts over the years to start individual courses in the arts and humanities, initiated by faculty, by residents, by students. Every year there's a new batch of sort of enthusiasm. But in the absence of an umbrella organization to offer administrative support, educational support, these programs struggle to provide a lasting contribution because medical students move on to the third year and then they're gone. Since the announcement of this academy a year ago, there's been a robust response from students, from faculty. I've had people so excited to finally teach the course that they've always wanted to teach, finally, have a concrete way of continuing the education they were so passionate about before they got here, and, people at the house staff level who are struggling with clinical issues and how to sort of use the arts and humanities to help themselves be fuller doctors. So I'll tell you about what we're doing. So there are courses that we have designed, and these are now fall courses that are going on for the first time, some of which have existed in the past in other forms, and like the Pulse of Art, others of which are brand new courses. And so I'll tell you about those. These are the courses we have this fall, and these are for preclinical students. We're starting focusing on the ones and twos, and with ambitions to then target the clinical students. Improvisation for medical students, the Pulse of Art, Music and Medicine, The Dream Machine, Words to Live By, and Narrative Medicine, which are two writing courses with sort of different purposes, and History and Philosophy of Science-Based Medicine. And so maybe at the end, we'll have an opportunity there are a lot of people here who are involved in leading these courses. They can say a bit about how the course is going, and sort of get to know the other course directors. So that's what we have for fall, and then there's a whole new batch coming out for the spring. We also have longitudinal experiences. So we had a seminar called The Art of Listening, or an experience rather. This was for the new medical students during the course of orientation, where they all gathered in 1301, and we had a lecture and performance by some physician musicians who are Sinai-based, who performed with their music groups, one a classical group and one a jazz group, that were groups of people who, some of them were doctors and some of them were musicians. And we had a discussion. We had an afternoon-long discussion about listening, about how musicians listen, about how they learn to listen, about how it's hard to listen, or how they help listen better. And then there were small group sessions that were led by Sinai faculty about this. And I say longitudinal because, this was, I experienced this as very, very valuable, and a lot of medical students told me it was a great thing, but it's really useless unless it continues, unless, these concepts are brought back to them as they evolve through their medical training. So this is sort of step one in several longitudinal experiences that we're going to provide for them. We have faculty development is a priority of mine for this program. So I see the people who want to teach and get really involved as core faculty in the academy, and there will be things to support them as we go through. And it's full of academic opportunities for faculty and for students to write, to publish, to do creative as well as scholarly work. So, we go back to our slide about the road to success in the medical humanities. Just to reiterate, programs have to be longitudinal, the art of listening being the sort of first step in that process. Now, we talked about programs having required elements or required entire programs. So my solution to this is really in the form of selectives. This is what most schools who have humanities programs that do well are doing. Medical students are adult learners. I think we're not on solid ground to say that this area or that area of the medical humanities is the most important. Nobody knows which is the most important. So letting medical students have some choice in terms of what they would like to learn more about, or what they're comfortable with, or what they never got a chance to learn before, I think is respectful and is more likely to have sort of a positive effect on the educational atmosphere. But it also sends the message that we think that this is important, and that you've got to take humanism seriously, and here are several different ways you can. So we talked about the dedicated faculty. The trustworthiness critique, I think it's important to have an MD in every classroom, just to make the medical students comfortable, even if the MD does nothing but sit there and let the other person teach. It's important for them to be there as a presence and as somebody who can make those connections for the students if they're needed. And then we have our first course in the harder medical humanities. Maybe we'll get a chance to talk about all the courses specifically later. But we've got a course this semester called History and Philosophy of Science-Based Medicine, talking about the question of evidence and how do we think about evidence, how do we use evidence, not just kind of how to navigate the medical literature and read a meta-analysis, but how do we actually make sense of all of that, including the complicated aspects of applying evidence in the context of individual patient care. So, and then in terms of our institutional validation, Dean Muller and I are working on providing several things for students and faculty: awards and fellowships, possible degree credentials, creating a concentration or a distinction in the medical humanities. These would be sort of analogous to the distinction in research or the distinction in medical education. These are things that are going to be competitive, that are going to be hard to get, but meaningful if they are attained. And opportunities for independent scholarship and a wide presence in the institution. So I'm wrapping up. Everyone who goes through medical training and engages in clinical practice struggles to manage many modes of thinking and many daily responsibilities. If we agree that humanism is important and should be taught, I've argued that sometimes it makes sense for us to go out of our typical milieu to do this most efficiently. That is, out of our own medical framework, our own language, our own faculty, and sometimes out of our hospitals. The medical humanities can serve the function of training doctors in core clinical skills while also helping to build reflective practitioners. Although there are elements of patient care and human interaction that are not well advanced by our conventional training, medical humanities can help us unlock these abilities and make our patient care and our lives in medicine more successful. So, thank you.